Good morning, everybody, and a really warm welcome to our community engagement event where we are aiming to support suicide prevention and self-harm prevention work across the sector. Today's focus is going to be on primary care and particularly making the links between the various parts, be that the health sector, the social care sector, or even community settings. So we hope you will enjoy today. Welcome back to those who've been to some of our previous events, and a warm welcome for those that are here for the first time. Next slide, please. Just a few housekeeping bits and pieces to keep us going. We're scheduled to be online for 1 hour, 40 minutes. And we are, because of the volume of stuff that's there, not enabling the audio or video for the members of the who are delegates, but participant cameras are all disabled, but you will see us and other people presenting. And the whole of the session is being recorded, so it will be available after the event for others that weren't able to attend to see, or for people to go back to if they want to. You can open something called closed captions, which allows the ability for what we're saying to be displayed on the screen in a text format. It's reasonably accurate, but sometimes can produce some fascinating and interesting results. As it's an engagement event, we'd love your questions. We'd love to be able to address the things that are bothering you and are connected to the subject today. But could you please put those in the question and answer function, which you'll find usually on the bottom, as opposed to using the chat, because the chat can be kind of missed and various other bits. So if you could please, and we'll try to present those questions to the presenters at the end of the 3 presentations. We're not going to be asking questions at the end of each one. We'll be combining them together, so it'll form as much of a discussion as it will be a question and answer. And after the event, we'd really welcome you putting your feedback on the day, so it can help to shape future events and learn from our own experiences. So thank you for that. Next slide, please. And finally from me, very most importantly, we are dealing with a sensitive subject that could affect us in particular ways. There's some ideas on the slide there about things that may be of help to you to consider and what support was there. I will just kind of reiterate that if you do find today it's being difficult for you in the sense of triggering thoughts or ideas, or you're struggling with some of the content, remember finding that safe and trusting person to talk to after the event in order to talk through what it was about. But please also consider, we are recording this, so you don't have to sit through it all today. Tomorrow, well, it won't actually be online tomorrow, but as soon as it's online, it's available there, and you may feel that you want to return to it in order to explore the things later on. So please don't just stay with us just for the sake of it. It will be available there, because your welfare and safety is the most important part of our involvement and for today. My name is Keith. I'm going to be leading you through today and working through. My background is in suicide prevention work. You can see in the bibliography the various other bits, but my key important bit is those conversations we can have to understand people's stories, because through that we can work through and make things the opportunity for change that will be there. We have 3 brilliant speakers for today, all providing a subtle different perspective on the subject matter that we're dealing with. And it gives me great pleasure to want to introduce, first of all, Linda. So if Linda would like to turn the camera on and start to share her slides, you'll find out more about Linda in the bibliography that and the bits that she presented to us. But basically, Linda brings a range of experience from a really wide variety of perspectives. And today she'll be sharing with us some of that vast experience in suicide prevention work, particularly in regard to the amount of work she's done over, sorry to say this, over many years, Linda, in terms of primary care and how that has helped to shape and influence what's there. So Linda's going to be providing, to some extent, historical perspective as well, keep getting us on a journey, as it were, to how we've got to where we're at, and being able to share from both an academic as well as a training and clinical perspective the primary care involvement. So Linda, it's with great pleasure that we welcome you to today. Starting these sessions is never the easiest, but at least then it's over with and you can listen to the other presenters later. So Linda, can I hand over to you?
Thank you, Keith. I'll just share my slides. And hopefully those are now visible. I'm going to be talking about, as Keith said, starting off really with a historical perspective on this subject. And I'm Emerita Professor of Primary Care Psychiatry in Manchester. I'm a retired consultant psychiatrist, but I spent, as my title would suggest, most of my career actually working with primary care and across the interface between primary and specialist care. I'm going to take you back to the days when watching consultations might have been exciting. I'm not sure how many of you can remember watching the TV in the days when it was black and white. I can, and I can remember watching this character as well. But there was a time when television was really, really exciting. And it was something that we began to draw on in the 1970s, both in general practice and in psychiatry, as possibly a means to try and look at what actually went on in GP consultations. So throughout the 1980s and the early 1990s, I spent much of my time working with GPs on helping them to acquire consultation skills, very specific to people with emotional problems, but those are have a broader application, using video feedback. What we learned really was that watching consultations can be very boring. They're not edited like TV programs. So you have to learn how to use, you have to actually learn the skills to use video feedback effectively. And I spent my time both researching and teaching how to improve the skills of GP trainees and how to teach GP tutors how to teach those skills using video feedback. And we developed a whole repertoire of skills. We also developed a number of skills training packages around depression, medically unexplained symptoms, and later we moved on into looking at suicide prevention. So this is an area that we've actually been working on for a long time, but I think what's most important for me to say is that GPs were up there right at the beginning in using TV and in using video and playback as a method for exploring consultations and in learning. I think far ahead, in fact, of psychiatrists outside of the academic setting. So I'm going to now take you a few years further forward. I finished doing a lot of the research into that in the early 2000s, but I did work for a time in collaboration with the National Confidential Inquiry, and they did some very interesting different kind of research into primary care, which I'm going to share with you now, because I think although it's quite old, it really provides some of the basis for thinking about suicide prevention in primary care. They looked at a 10-year study of attendance and clinical factors using a case control design between 2002 and 2011. During that time, there were 2,384 patients who died by suicide. Over half of those had seen their GP for a face-to-face consultation within the previous 12 months, which is something we know. We always say that people do consult regularly. What is interesting, of course, is the characteristics of non-attenders. And as you would expect, they tended to be male and younger. But there were some people who were very high attenders, and they also had higher risk too. When you look at the patients who died by suicide, their consultation, diagnosis, treatment, and referral, the number that had a mental health diagnosis at any time during that 1 year period was 63%. And that's quite a lot, really, when you think about it. Of the patients with no diagnosis, 37% were male, aged 35 to 44. But 71% of people who died by suicide and had presented to their GP had a diagnosis of suicide, of depression. And I think that's really, really important to remember. The association with depression is something that we often lose sight of when we're talking about suicide prevention. But depression is something I'm going to come back to because I think it's just so incredibly important in thinking about how we've arrived at trying to achieve zero suicide. When you look at the people who'd had psychotropic drug prescription, almost half of them had. And there was a group, the group that were most at risk were 5 times more likely to have had psychotropic drugs prescribed. 31% had been prescribed more than 2. And there was certainly elevated risk with 4 or 5. Referral won't surprise you at all. I think the situation has changed very little over the last few years. And I don't think this is in any way an indication of GPs not wanting to seek help. It's that they don't refer when they don't think there's much opportunity of people being seen. And only 8% of people who died by suicide had actually been referred to specialist mental health services. I think that's something that those of you working in specialist services must always keep in mind, that you do not see more than a minority of people who take their own lives, that the majority of people are people out in primary care who may or may not actually be consulting their GP. One of the things that I spent a lot of time trying to teach using video feedback were these first 3 skills. How to engage someone empathically, how to assess risk, and then more recently, making a collaborative safety plan. I think we grossly underestimate the importance of empathic engagement. If you haven't engaged a person in meaningful conversation, then I think there's very little chance that they're going to really share with you what's actually going on for them. And making a safety plan is an important step which requires that collaboration. More recently, I think we've become much more aware of the need for training in the care of those bereaved by suicide, something which very powerfully came home to me during the pandemic when I was helping to set up the Greater Manchester Bereavement Support Service, that many of the people who contacted us had been bereaved by suicide, some of them many years ago, but they still needed help, and suicide was a significant risk in that population, around 40%. The National Confidential Inquiry have put together their Safer Services Toolkit, and they suggest some things that are particularly applicable to primary care. The first is safer prescribing. And I think most of us are aware of this, but don't always think about the presence of painkillers as well. Opiates are the most commonly used type of drug in fatal overdose. We think about analgesics and tricyclic antidepressants. All of those are important. Reduced short-term supplies. we need to ensure that there's a mechanism in place to assess regularly the mental health of people with major physical illness. We know that during that period, a quarter of patients who died by suicide had a major physical illness, and that risk rises to 44% in patients aged 65 and over. I don't think we pay enough attention to this, and I think primary care is a crucial place for that, because so many people there, older people particularly, but younger too, have physical illness with complicating mental illness. And then, of course, 71% of people who died by suicide and presented to their GP had a diagnosis of depression. So how can we actually improve depression care? Well, that's a question I've been working on for the last 30 years. When I first started to work with video feedback, we were helping doctors to ask questions about depression, helping other people in the practice, trying to teach practical management skills using video feedback. I think it is very possible to acquire those skills, but we need support and backup when doctors and other people working in primary care can't manage people with more complex problems. And I think there needs to be that proper backup for further support and assessment. And I think the fact that only 8% of people had been referred means that many doctors understandably feel that there isn't much point sometimes in referring, that their referrals will get knocked back as not meeting threshold criteria, and that people who they send to the crisis team will also get knocked back as not being at immediate risk. Both of those, I think, are problematic. So is that support actually available, and how could it be available? I followed the Zero Suicide Initiative research with interest, because when you look at what was actually published originally with that in the US, what it was actually primarily first about was building a better system of care for depression in a behavioral healthcare system. It was actually the Henry Ford healthcare system, because in the US, you get your healthcare via your employer, and they actually had their own mental health care service. So it was within a specialist system, but they were really trying to drastically improve their depression outcomes. And to do that, they employed something called collaborative care, which is what I've probably spent the last 20 years or so researching. So I do know quite a bit about that. Collaborative care is a way of working together between primary and specialist care. It's a way of systematically following people up, a case manager working with a GP under regular supervision from a specialist mental health clinician. When we rolled this out in Salford at 6 Degrees Social Enterprise, which I worked for many years, I and others did the supervision, but we did have primary care IAPT Step 2 workers working as the case managers, a structured management plan of medication and brief psychological therapy, actively following up people who didn't attend, and enhanced interprofessional communication, actually sharing, being able to access the GP records and leave notes for the GP, which the GPs found extremely helpful. Collaborative care has been demonstrated across numerous trials now across the world as being the most effective way of treating depression and anxiety. Sadly, it hasn't been rolled out within the UK, despite the fact that we did a large study of it and demonstrated it was possible. And that's because the model in the UK has been for standalone psychological therapy to be provided in IAPT services. What the new NICE guidance says is to consider collaborative care, particularly for older people with depression, particularly if they have physical health problems. Note the comments I made earlier, and for people with more severe depression. But how it will actually be put into practice is the issue. I think it's really important to note that when Justin Coffey, who was involved in rolling out the Zero Suicide Initiative for behavioural health services, when they actually rolled this out to primary care, to get primary care engaged in it, they actually said you can have immediate access for any patient referred as long as you've been following the practice guideline. No questions asked. In other words, no knocking back. So in order to roll out Zero Suicide, they really did provide that essential backup, which we don't have in this country. And I think that's really important. I don't think you can just say, this is what we're going to achieve. You have to think, how do we achieve that? One of the things that is happening at the moment is that certainly within England, we've got the Community Mental Health Framework, which is going ahead. And the aim will be to have mental health services closer to primary care, but we're still working out exactly how that will happen in practice. And I would really love those people putting it into practice to draw on some of the evidence from collaborative care. What tends to happen though, is the world gets reinvented, the wheel gets reinvented, and people don't draw on what we know to be effective models of practice. So to summarize, we know that the majority of suicides in people not known to specialist services, many of them are known to primary care. There are three things that we need to think about in terms of suicide prevention in primary care. Training in suicide prevention and postvention, which needs to be tailored to the primary care setting. It needs to be available at the right times when GPs and the practice team can attend, but it can be done. I know because I've done it. We need to really be serious about safer prescribing, and we really need to think about how we can seriously improve depression care. And that doesn't mean prescribing more medication. In many cases, it may be prescribing less medication. It's about providing support for primary care and backup, as well as putting evidence-based models into practice. So I'm going to end there. Before I do, I'll just draw your attention. Primary care mental health is now, it's a developing specialty across primary care and mental health services. And the second edition of our book, Primary Care Mental Health, was published 5 years ago now, gosh, 4 years ago now, and it's widely available. And I've also written about my own personal experience of having mental health problems. So I can see this really from both sides of the desk. And those are two books about my own experience of both experiencing better care for depression. Thank you very much.
Thank you, Linda. Thank you for sharing that and taking us on that journey, as it were. For me, there were some bits that really resonated that maybe we'll pick up on later. And please, can people ask questions in the question and answer bit that we can then come back to? Because I'm sure it's already stimulating. You know, those consultation skills, I think they're vitally important, but having the confidence to do that consultation, to be able to ask those questions, because to be able to engage empathetically means that we can get the person to be telling their story, because if they can't tell their story, how do we know what's affecting them? And in terms of what we can do, there's, you know, unless we get the story in the background, we won't know what things that might be of help, because some of them, maybe it might be depression there that it needs the care, but there might be other factors that are causing the distress and the despair, which may have the interventions. And that's where that collaborative care fits in. It's the parts of the system being engaged that can help to support the person And effectively, the best collaborative care is with the person themselves as well. So we're working through, which is probably where the safety plan bit fits in. So thank you for that, Linda. I think that was a really fascinating way of starting today, and we'll build on that as the day then progresses. It gives me great pleasure now to introduce Faraz. And his main research area is in the field of self-harm and suicide prevention in primary care. So really very much ideal for today. And I guess it brings to the surface as well that we need to be thinking about self-harm as well as suicide prevention, because they can be so interconnected. And, you know, as a proxy for future suicides, we know that having self-harm is one of the strongest risk factors that's there. So maybe we need to be considering that and how we manage all of that. So Faraz brings to us a vast amount of experience and evidence supporting that role for primary care in self-harm and suicide prevention and how it fits into the overall prevention environment. So thank you, Faraz, and over to you.
Thank you very much, Keith. Very kind of you. Are the slides up and are they okay? So I'm assuming the slides are showing fine.
Yes, they are. That's fine. It's very clear. Thank you, Faraz.
Perfect. Thank you. So no, it's a pleasure to be able to be here today. Really enjoyed that first talk by Linda. So my talk today is entitled Suicide Prevention in Primary Care, Insights from Research Evidence. And I really wanted to bring to the table today what the evidence has highlighted over the years. So a little bit going back over the years about what's been conducted, where things have moved from, and also consider future research considerations in this really important area of improving the detection of suicide risk, and in ultimately preventing deaths by suicide in community and primary care. So a little bit about myself. I'm a GP in the NHS, researcher at the School of Medicine, Keele University. And just to highlight declarations, I currently sit on the NICE Self-Harm Clinical Guideline Committee as the GP. I co-chair the IASP Suicide Prevention Primary Care Special Interest Group and have received research income from NIHR and the Royal College of GPs on self-harm in primary care. So to begin with, a little bit of a dive into history. And throughout the presentation, I've tried to keep the focus on the UK, thinking about transferable findings into the NHS and England specifically. But some years ago, I think in the 1980s, there was some work in the US of A where they really were interested in looking at service utilization prior to suicide in primary care. And this just highlights that people were keen on exploring the potential to identify suicidal behaviours and suicide risk in primary care some years ago. So by public health colleagues in the British Journal of General Practice, again around about the 1990s, researchers in public health were really interested in exploring general practice patient records to try to identify risk signals and factors that may be associated with deaths by suicide. So really highlighting the use of GP records and patient data in primary care to explore that from a research point of view. And then the evidence matured, and Lewis Appleby in the British Journal of Psychiatry published before 2000 an important piece of work looking at young suicides in the Manchester area, and really looked at the number of GP consultations in that 3-month period before suicide, and found that perhaps unsurprisingly, frequency of GP visits increased quite a lot before suicide, more often in males, which we know are a higher risk group, and again highlighting the importance of thinking about GP consultations and making every consultation count, and trying to really highlight the potential of every GP consultation. So now moving on from, as I said earlier, around the potential of GP data and GP records, things have changed somewhat, and now we have really good infrastructure within primary care. So what used to be called the GPRD is now the Clinical Practice Research Data Link, which houses anonymized patient records from general practice all around England. So from several hundred GP practices, and what you end up with is a large amount of anonymized patient encounters in general practice. And a group of researchers from the University of Manchester have been using CPRD to really look at the epidemiology of self-harm in primary care. And we know that self-harm is at the moment the most important risk factor for suicide in terms of the level of risk it has in death by suicide, around about 50 times the history of self-harm in a person. And this piece of work published in the Lancet Psychiatry really showed the importance of identifying self-harm in older adults and trying to support older adults, because through CPRD they found that a history of self-harm in older adults increases the risk of suicide by around 150 times, so 150% increase in risk of death by suicide if an older person has a past history of self-harm. So, you know, a really important finding and extremely high in terms of subsequent suicide risk. Again, using CPRD, colleagues in Manchester explored a different question, and this was around the amount of GP consultations people had, psychiatric diagnoses, and the number of mental health medications they were prescribed. And perhaps unsurprisingly, those people who had quite often GP consultations with several, I think more than 5 psychotropic medications being prescribed, were found to be at an overall heightened risk of suicide. So it's really important observational research using primary care records to really highlight key targets where early intervention can be developed and thought about in primary care. So now moving on to what can GPs do about suicide prevention in the consultation. An important systematic review, gathering all the evidence from trials and other types of observational studies conducted by colleagues in Australia, found that when thinking about GP training specifically, which is really important, Linda talked about skills training. GPs are still at the front line of the NHS, and what they found was, although only a small number of included studies were found in this pooling of data from these different types of studies. So here you've got randomized controlled trials, you've got uncontrolled studies. What they found for suicide attempts specifically, so suicide attempts including self-harm by cutting or overdosing perhaps, were that these types of GP training interventions were not really helpful when grouped together. But of course, there's only a small number of included studies here, so there are limitations. When thinking about GP training interventions and the effect that that can have on death by suicide, so this chart here with the arrow shows that actually GP interventions from uncontrolled studies, so from pre and post intervention studies can have a favourable effect on reducing deaths by suicide. So we can see at the bottom of this figure here, under 20.4.3, around about, I think it was 8 or 9 included studies here, led to an overall positive effect on these types of interventions that GPs were trained up in on subsequent deaths by suicide. Now, we don't know, they are going to be different interventions for GPs across different countries, so that has to be taken into account. But again, it highlights the potential of training for primary care clinicians. And in terms of the NHS, we need to think about this in more detail and think about skills training, especially now moving forward with the long-term plan in a new context, I feel. Moving now slowly into self-harm, which is some of the work I've been looking at over the last 5-6 years. We know that GPs are seeing patients who self-harm more often in practice, and groups like young people and older adults are high-risk groups. But no one had really looked at what GPs can do in terms of for patients in the consultation who come to a GP with a history of self-harm or current self-harm. So we looked at all the international evidence and synthesized that together to really elaborate on the role of the GP in the management of self-harm. And what we found was that the GP has a multi-dimensional role across 3 domains. So frontline assessment and treatment, referring to specialist care, and also looking after self-harm by themselves within primary care teams. So that was important to just outline and delineate in the evidence base for future work moving forward. We also looked at barriers and facilitators to effective GP care in the consultation for self-harm. And what we found was that GPs wanted more time in the consultation, and some GPs lacked confidence in handling self-harm. GPs were unable to really lean on any specific self-harm services, and there were local and systemic factors that affected the management of GPs, management of GP-led care for self-harm, such as waiting list times for specialist services and also GP workload. In terms of facilitators, we found that GP training is important, especially around communication skills and handling challenging consultations for self-harm, that we really needed to improve the communication between primary and secondary care services, that GPs felt regional co-produced self-harm guidelines can be helpful. How GPs involve parents and families of young people is important. And also, again, and this links on nicely to the self-harm integrated services that are currently being developed around England in alignment with the long-term plan. The GPs were really keen to be able to lean on where appropriate self-harm services in the community. We've done a little bit of work on self-harm in young people, and really around the potential of the GP consultation. And in this editorial, we just highlighted the importance of youth-friendly practices and habits and building that culture in primary care teams. And this review really outlined the importance of not only more research, but that general practice does have an important part to play in young people, in young people's care for self-harm. But there is a need for a lot more work to understand what we can do. As part of that, we interviewed young people who had an experience of self-harm. So from the ages of 16 to 25, we conducted interviews around England with 13 young people. And they really highlighted and described the importance of good GP consultations, as that would influence future help seeking for self-harm in the future. And they also identified that continuity of care with the same GP was important for them in their self-harm care. So from that qualitative piece of work, we generated recommendations for GPs looking after young people with history of self-harm. I'm not going to read all of them out, but a couple of important points are really to explore the type of self-harm, the nature of self-harm, and to document clearly in the patient records, and also to, even if young people are on waiting lists for perhaps specialist services or IAP services, it's still important to follow young people up in primary care while they're on a list for further support. And even if they're actually receiving that specialist support, young people valued ongoing continuity of care. So not only young people, but qualitative work has been conducted with older adults around experiences of primary care for self-harm, led by Isabella Troyer, now is at UCC in Ireland. But from this piece of work, again, similarly, general recommendations were identified for GP care around older adults with a history of self-harm. And some important points to take into account here. Again, follow-up's important as part of the overall management plan. Perhaps thinking about longer appointments where appropriate, and GPs quite often do that for different health problems. And I think with older adults, there are at the moment, there's quite a lot of availability of third sector organisations, and it's important to liaise with community and the voluntary sector services to support the overall self-harm care for older adults. So moving away from GPs, community pharmacy is an important aspect of primary care. And Hayley Gorton and colleagues conducted a really important qualitative study asking community pharmacy teams on their views about how community pharmacy can support suicide prevention. And a couple of important themes I've picked out are the relationship with the patient is important in community pharmacies. I'm sure a lot of us here have experience of going into community pharmacy, either collecting or buying something over the counter. And actually, generally, people go to the same pharmacy quite often, and quite often it's adjacent to the GP surgery or in that primary care centre if you're with a larger GP practice. So that can play an important part in terms of mental health distress, perhaps around self-harm, thinking about preventing suicide, but also importantly the pharmacy environment. And this has come up in some GP research around, especially with young people valuing a welcoming environment in primary care in a GP surgery. Similarly, in community pharmacy, that's been identified to be important. So I wanted to bring this quite old trial. This was published in the BMJ early 2000s by academic liaison psychiatrist Elspeth Guthrie, but it's actually at the moment, I think, the only randomized control trial of an intervention that has shown some effectiveness at helping people with a history of self-harm. And in terms of the overall suicide prevention agenda, it's important to think about interventions for risk factors that can lead to suicide. So Linda talked about collaborative care for depression, which is absolutely important. In terms of self-harm trials, really there's a real lack of evidence in the NHS. So this trial was specifically around people with a history of overdosing, and people were recruited from accident and emergency departments and offered a brief interpersonal therapy, which was delivered in the community in their homes by trained nurse therapists. And this brief intervention would be 4 sessions of around about an hour therapy. And very interestingly, this led to significant reductions in repeat self-harm. And people who were part of the trial were quite satisfied with receiving the intervention arm. I think this is a really good example of working across the interface. So recruiting from secondary care, delivering the intervention in community care, and could be an example of how to think about future trials in this area moving forward. So I wanted to, coming towards the end now, I wanted to just highlight a couple of again, research studies conducted by colleagues up in Greater Manchester, using CPID against anonymised patient records in primary care, around how we can target people who may have higher suicide risk. So we often know that people with mental health distress do have physical health problems. So the first study in the top corner here highlights that females who were younger than 50 years of age were actually had a significantly higher risk in comparison to older women with lots of physical health problems. So physical health problems that led to an overall increase in suicide risk included ischemic heart disease, COPD, and osteoporosis. And through this observational piece of work, they identified that a lot of this was explained by underlying clinical depression, which is really interesting. And secondly, this piece of work on suicide risk in primary care patients around personality disorders highlighted that those people with a diagnosis of borderline personality disorder and borderline personality disorder and comorbid alcohol use were at a significantly higher risk of suicide compared to those without. So more recently, we've tried to really push the agenda again through journal publications on really highlighting primary care as a place for early intervention. Done some work around thinking around primary care in COVID and suicide prevention. So in this editorial, we highlight concerning clinical features in primary care and how COVID has exacerbated some of those risks. And also thinking about the wider primary care team, a small piece around the upskilling of community dentists as part of the wider primary care team. So just to come towards an end, but just to highlight that the NICE guidance for self-harm is due to be published shortly. In there, we have new recommendations for primary care, including GPs. There's lots of interesting work around prescribing, so do keep a lookout for that. This piece of qualitative work, published 2017, I wanted to highlight this just to show that people who have been bereaved by suicide and GPs have identified areas of concern, such as over reliance on certain mental health prescriptions, antidepressants, and also structural problems in mental health service provision within health systems. But this was from Ireland, so not exactly how the NHS works. And to conclude, I've got here 3 areas of future research I think are important to kind of move the field forward and where I think things need to go to. So firstly, for the individual person in practice, it's around early intervention and assessing new interventions and their effectiveness. Secondly, it's considering the wider primary care team, and training can be key, but evaluation is important. And finally, we need to think about cross-sector approaches. So very much in line with your suicide prevention, cross-sector teams in different areas. But to do that, we need a systems approach to evaluation, which can be complex, thinking around complexity and system theory, for example. So thank you for your time. My email's there if anyone wants to get in touch, and I'll hang on to answer questions too.
Thank you, Faraz. I guess we're building up quite an interesting picture about what we know and what can make a difference. And there's an awful lot that we do know, and there's an awful lot that can make a difference, but there's still stuff that we don't know and working through. And I guess for me, that bit about working together, the important role, if we take the mantra of suicide prevention is everybody's business, okay, we can all make a difference, but actually we all need to be working together and collaborating together and communicating together. Which maybe brings us nicely on to our next speaker. It gives me really great pleasure to introduce Sohrab, who I've worked alongside now for a number of years in the field of suicide prevention. And he's going to bring us a perspective, I believe, about what it's really like currently at the interface between the person who's feeling distressed, but also what it means in terms of communities, not just practices, not just general practice, but actually how it fits into the overall suicide prevention approaches that are being taken at local level. So Sohrab is going to give us that perspective, including some of the potential challenges and obstacles. I think we've alluded to them already, and I think Sohrab will share some of those as we're moving along. But also where it links, not just with health, not just with social care, but also with individuals and communities. And Sohrab has had an influence on those in our own locality, as well as in a national context. So it's with great pleasure, Sohrab, I hand over to yourself.
Good morning, everyone. Thank you very much for the introduction, Keith. As we've just had two amazing talks, it's very hard to know how to follow either of those or both of those. So thank you for those talks too. But I hope to be able to add a little bit of difference to maybe some of the discussions. So let's crack on. My history is as a GP primarily, who then ended up developing some interest in commissioning, and particularly mental health, learning disabilities and suicide prevention and so on. So that seems to be where I've ended up, and it's because it's deep in my heart that I want to make a difference in these areas for a range of human reasons, if you like. I do have a system view as well, so let's move on and we'll see if I can add anything to what's been discussed so far. But before I start talking, I thought we'd break things up a bit, just have a quick poll of the audience, get your view on something. So I also am on the steering group for the National Suicide Prevention Alliance, hundreds of organisations that come together to try and share their experience in how to prevent suicide. What I would like, they just looked at 59 of their members who've got lived experience to ask them basically how their experience is with their GPs. And they were asked, was your GP empathetic, knowledgeable and understanding about your experiences in relation to suicidal thoughts and actions? A difficult question, but a group that are experts by their own experience, as it were. So I was wondering if we could all do a poll, have a look at the options A to E and see what you think. So this is just to break things up, get things started. So there's the poll. So if everybody could, in the next 10 seconds or so, select one of those. There's no prizes and there's prizes for the winner, but it's just interesting to see. So if we could wait another 10 seconds, 5 seconds, 10 seconds, and then we'll come up with what people actually think overall. Okay, how's that? So what the results were, 21% thought 30% 33% thought 21%, but the overall is 46%. And 18% thought 63. So actually, funnily enough, you're spot on. 46% of them said that they were happy. And you're all right. I think that just shows what an amazing first two talks you've had, because it's given you a real feeling for the subject as well as your own experiences, of course. But it is interesting to see, how do I move the slide on? Just a second. Right, the actual answer 46. Now, if you were to put it into the perspective of I'm feeling suicidal and I'm going to try and get some help, 46% doesn't feel great. It's kind of like flipping a coin. But before we start complaining about the experience, we have to understand that that means that more than 50% of these experiences were very positive, and they were very happy with the GPs, and that's despite the fact that GPs are under enormous pressure and don't have necessarily the support that they always need, don't have the backup, etc. So I do think that that is both a good and a bad answer, if you see what I mean. We need to improve it, but it's not a criticism of the GPs. On a personal perspective, I'll just leave that there for 10 seconds for you to quickly read, because it's easier to read than for me to say. But I do feel that this is such an important area, and it's only in the last 10 years or so that I've actually been able to get to grips with it. Before that, I think it was like an unknown, untalked about area in primary care to a large extent. So I do think that we ought to move forwards with this subject. Moving on again, so I won't repeat all the challenges that we have in primary care, except I will just point out one or two things. We've got 100 million mental health consultations in primary care a year. The pandemic, of course, has changed a lot of things. It's made the stress on the communities, more and more depression, more and more self-harm. There hasn't been an overall increase in suicide rates, but there has been in certain aspects of that, to different populations, because the pandemic has not affected everyone equally. There are people who've had a harder time than others, and that fits in quite well with the inverse care law and inequalities. The gaps that traditionally GPs have holding patients are historic. I think most of us know them, so we have those to deal with, and hopefully we're going to address those. Moving on to the right-hand side, the number of barriers all mentioned there to do with why GPs aren't doing better, or they are trying to do better, but they need help, I think. The Lived Experience Network did comment on specifics. They did talk about the lack of face-to-face contact. This was during COVID. They felt there was some lack of empathy. And remember, it's very difficult to give compassion if you as an individual are already compassion fatigued. So maybe some of that is due to the workforce stress that people are having. The appointments being too short is always an issue. And I think we ought to have an honest debate within the health service as to why we are talking about a 10-minute appointment for someone who has a mental health condition. If you dig back into history, you'll probably find the whole thing's very arbitrary, and you wouldn't give a 10-minute appointment to someone who's having a heart attack in the surgery. So it is something we need to have an honest and open debate about. It's not easy, but I do think that's an important area. So continuity of care, by the way, just going back, is really key for once you've developed a relationship with your doctor. Moving on, now in Derbyshire, talk about training GPs. It became evident through public health, we actually had a lot of GPs not trained in primary care, in suicide prevention and self-harm. So what we looked at was, rather than, we'd already trained a lot of the public, and of course the Mental Health Trust had their own plans for training their own teams, but in terms of primary care, there was basically very little or nothing. And so we set about trying to address that. and we trained up, we got trained up rather, 8 local GPs to deliver suicide prevention awareness training, 2 primary care healthcare workers, and we've nearly reached 1,000 staff now, of which half are clinical and half are sort of non-clinical. So the actual doctors and nurses is 50% of that. And the focus is, we did win almost win an award for that. So it was innovative, and it was awarded that because of the fact that it was peer-to-peer and it was very successful. So anyway, then a COVID came, and for 18 months we didn't do anything, and now we're trying to get it back up and running again, but online. Focus of that was compassion, safety planning, risk mitigation, means restriction. Now these are things that actually, as a GP, my training historically came back, were not particularly well taught. You were taught about depression, psychiatry, antidepressants, and so on and so forth. And yes, it's very, very important, as Linda said. Why did that happen? As Linda said about perfect depression care and making sure all those things are in place, absolutely. But you do have these additional skills, which are both a combination of human skills and also a combination of practical skills to do with risk mitigation and so on. Sorry, means restriction and so on. Forget prediction tools, they don't work. Nice guidance says don't bother with them. No way that a prediction tool is going to tell you who isn't going to die by suicide. So we now know that that's a waste of your time and you're better off doing these other things. We do have a very good public health service here that looks at hotspots and demography and takes account of, hang on a second, I don't know why this, I'm on the right hand side, let me just get rid of that there. So yeah, it takes account of all, you know, any suicides that are happening on the trains or any other similar patterns that have developed. I meant the train tracks, and feeds that back into primary care in a very successful way. So that's helpful. So what have we learned? We've learned that primary care really want it. Why do I say that? The waiting list is there. They all say they want this suicide prevention training, and it's been an area that's been sadly neglected by, you know, historically in terms of the whole country, really. We do have to offer flexible training, like Linda said, and it needs to be evidence-based, like for us talked about. But we do need to think about how we can train up different aspects of the workforce in a unified way. And you will find that they are very happy about that. So it's not just about primary care. Whoops. It's also about the whole system. During COVID, we as a system, you know, I work for the ICS as a clinical lead, have set up a 24-hour all-age mental health helpline, which has been enormously successful in terms of popular with GPs, actually, because, you know, they give this helpline out to people all the time, you know, as part of the package, when not instead of caring for them, I would hope, but as well as, you know, saying, you know, if you get a problem, then in the meantime just ring this number and you will get to talk to somebody who is a P3 or a peer support worker trained in this. And as you can see, the highest number we've had so far, 2,500. It's more like 2,000 now, but at the peak it was 2,500 calls in a month. 300 of those might have a suicidal component. But the vast majority of those, I'd say, of those 300 are de-escalated successfully by the P3 trained worker. Then the mental health workers, the actual psychiatrically trained nurses and things, are also there to take over if the call requires it. And of course, it's linked with other agencies. Brilliant service. We need to look at how to develop that in the future so it interacts better with all the different aspects of the service, because obviously it's quite a challenge. We also have these alternatives to emergency services now, like the Safe Haven. You know, why does someone always have to go into either a hospital bed or go to A&E? You can send them to this Safe Haven, and there's a crisis house as well, where people can stay with support from the primary care team. The crisis team. Crisis teams are expanding, are being invested in, and obviously that's going to be key because they have been, I think, under-resourced at times in the past. And we also have an emotional health and wellbeing website, which I'm very pleased to say is very well received. It's all mental health information and or services for Derbyshire, and it's all ages, and it's been set up especially over the pandemic. It's been launched recently, and it's fabulous. And it includes options of, you know, different training for different people, also different services. So anyone can use it, from, you know, a patient to a doctor. I will just point out, we put on there primary care post-vention support pack. Why is that important? Because primary care often feels really quite, you know, stressed, both as an organisation and or as an individual GP, for example, if when a patient dies by suicide. They have all the family to help, they have their own inner feelings to think about, they have, you know, reflections to do, they have paperwork to fill in, and they have the coroner's inquest, etc. And so this pack, do have a look at it. It's on the website. Is aimed specifically to help them. So future opportunities for improving suicide prevention in primary care. I wanted to say, you know, we are working in changing times. There is a tectonic shift happening at the moment. The landscape is changing. As Bob Dylan says, the times they are a-changing, which shows my age. And so we've got these, ICS, training, IAPT, primary care, community mental health framework, and social prescribing. I'll run through some of these. ICS has the ability to bring together the strategy and address the inequalities. I think that's really important, because for too long, the distribution of resources across the, say, for example, a county can be inequitable, can be historically built. It's the same with primary care. You could have all the doctors in one part of a county and none in the other. You could have all the mental health nurses you like, or district nurses in one part but not another. We really need to address the inequalities in both populations, but also in regard to the way services are designed. And we can also, as an ICS, look at the systemic training that we need across the patch, just like Faraz mentioned earlier. He said something about systemic or system-based approaches cross-sector. So we're looking at that right now. The training, as we said before, there is a need for skills training within general practice. There's also a need for information training. There's a need for local networks training. I do apologise that. And we need to look at the training being bespoke according to the needs of that individual person's job and team that they work in. So there's a paper there you can look at which goes through quite a number of different options which have been looked at by Health Education England, for those of you interested to look at later. And then, because I won't be doing that today, and then IAPT, we need to remember that IAPT is there. It is standalone, but we're trying to get it more integrated in the 10-year plan, and we're trying to get nice guidance to look at this more carefully, because you see, IAPT should not and does not exclude suicidal thoughts or patients. It's there to treat depression and anxiety, not specifically to treat suicidality. But it should hold on to patients unless the reason for referring someone back from IAPT to saying it's not appropriate, etc., should be looked at more carefully, because in some areas it's working well, in some areas it's not working well, depending on the organisation and or the training of the staff. They should be able to manage a lot of those patients unless they are too complicated for them and need secondary mental health care, or unless the therapy has stopped working. We're also building IAPT into a system more and more where employment support is offered. Far too many people with long-term mental health conditions are unemployed or unable to work, and I think that's has a huge effect on whether or not they may or may not recover and their lives. Back to the community mental health framework. So some of you will know this is the long-term plan for changing the model so that it becomes more whole person population based, aligned with primary care networks. The old CPA system, it still exists, but it used to create a bit of a two-tier system. You either did have a CPA or you didn't, and if you didn't have a CPA because you weren't complicated enough, then basically it didn't always work out that you got the right treatment or enough treatment. So we do now have a focus on any level of need here, the core services, followed by complex mental health needs, which will be including things like dual diagnosis and personality disorders and SMI, which is serious mental illness, I should have put on there. But depending on the complexity of the needs, the complex team will also support the core team. And the core mental health services will be place-based and integrated with PCNs. So primary care focus. So the idea is to get rid of referrals, thresholds, transitions, and discharge to no support, and replace it with things like maximising continuity instead of a cliff edge, giving people choice close to home. Future opportunities, primary care networks, well, you know, I mean, because the workforce has been under the cosh and because primary GPs are getting scarcer, it seems, we have the additional roles reimbursement scheme now. First of all, a shout out to primary care network. I think they're a great idea. I think they're fantastic to bring teams together like this. And they have stepped up to the mark in terms of the COVID pandemic, in terms of being able to vaccinate the population and so on. I can testify to that from the calls that I'm on as a leader, leadership calls, the huge amount of work that they've done there. In regard to the community mental health framework, they're getting this additional roles reimbursement scheme. Actually, it's about it's not about that specifically, it's about the GP contract to help promote and support the capacity within primary care. We now have the ARRS, unfortunately named, scheme, which includes social prescribing link workers, crucial to helping people who are needing help with the traumas in their life, with the difficulties in their social isolation, for example, is the key area. Physical health.
So Rob, would it be possible to just flash up the next few slides so we can move on to the question bit? Okay,
I will, yeah. I didn't see your thing, okay. Mental health workers, clinical pharmacists, technicians, and occupational therapists. Then on this slide, I will skip this slide. This is about the different aspects of the consultation and how you can look at different areas of the consultation, as far as says, during, before, and after, to support the best practice. And this slide shows how we are doing it in Derbyshire from a ground upwards way. We are trying to make sure that this is not just something that we're doing slowly. This is from top down. We have got co-development and co-production going on throughout the county, bit by bit, to make sure that everything is going to be patient orientated. And if you look at the link at the top, you'll find out much more in a video on that. So in summary, primary care is crucial. Lived experience will tell you some of the problems. The workforce need and deserve parity of esteem. The ICS is providing, for training. The ICS is providing enhanced services to support mental health and primary care. The framework and the PCN developments give an opportunity, like Linda said, to promote collaborative care going forwards. And the GP workforce are under strain, but given the right support, they can rise to the challenge, I believe.
Thank you, sir. Much appreciated.
Can I just leave that slide up for a second? If anyone wants to respond to the government discussion paper on primary care and mental health, there's the link and there's the deadline. Please do do that at some point in the next few weeks.
Wow, we've had such a lot of rich information that's come forward for this morning. We have a number of questions and points that people are wanting to raise. I wonder if I could ask all the presenters to come back onto camera, and then we'll address some of the bits that have been raised. And those areas that we don't manage to address during this presentation today, we will see if we can respond to those questions at a later date in terms of that. Okay. Questions just vanished. I guess one bit that's cropping up quite regularly is the acknowledgement of that need for training, that need for equipping and skilling the workforce. Now, today is not about advocating one particular product over another or what is the best one to go for, because this is about our engagement with the community. But I wonder if our presenters might want to share what they think they should be seeing in a training package for GPs, because I suspect not one will fit everything all together. And maybe perhaps, as Sarab kind of mentioned the training that was happening in Derbyshire, and perhaps give us some insight into the things that were needed. Maybe could you reiterate what you thought was needed for the GP training? Because as you say, many of them felt that they never had or hadn't had sufficient. And what do you think they've benefited from? You gave those ideas about their compassion and reduction, etc. Do you want to just expand on that slightly, Sarab?
Yes, certainly. So one of the things is about teamwork, because suicide is everyone's business and the team needs to all understand the issues so they can talk to each other. Otherwise, historically, people don't want to bother the doctor or something like that, or they need to be able to understand how to deal with the distressed person in the reception room or on the phone. Secondly, there are issues to do, primary care, doctors often come up with the 10-minute appointment thing and so on. One of the advantages of myself and my colleagues doing the training was that we could say that we've actually put this into practice and we have benefited, but also the patients, have benefited, but we have changed our practice completely. So the way that I deal with someone who's suicidal, and so do the people who I'm talking about who've been in the training, they now understand that, there are certain things that you need to really do in that first consultation. Like Linda said, you've got to make that connection. But you've also got to then, you have as a GP the opportunity to look at safety planning straight away, rather than thinking 10 months ahead about, a whole depression pathway. You need to think about safety planning straight away. You can actually do that. And also you can have continuity of care built into that, giving people safety nets and review opportunities. So I might have 10 minutes, I might have 20 minutes, but I can also have another 10 minutes later in the week or next week or something and give them backup. Because we're GPs doing this in practice, they understood that and accepted that, as opposed to saying, oh, psychiatrists have an hour or whatever they might say. So that was very helpful.
From the research that you've done and the feedback, particularly related to the self-harm side of things for us, is there anything you want to add into what we should be looking for in terms of primary care training? Or sometimes the question was about GP training as well, in terms of what we should be looking for.
Yeah, so in our systematic review, we found that GPs wanted training on young people communications specifically, challenging consultations also. From some of the qualitative work that we've done, those recommendations for clinicians in primary care, they can also, they're important to take into account from stories from people with lived experience of self-harm, to incorporate those into future primary care training. And I think generally it should be within the evolving GP context. Things are changing, as Sorab elaborated on. In terms of GP trainees, that's slightly different in terms of a lot of their trainings led by Health Education England and their training schemes in the regions that they're in. But things like the training offered by people like STORM and services around the country are options and avenues of trainees currently to access so far.
Thank you, Firas. Linda, you started actually in this kind of arena with your presentation, because it was about those experiences, although it was actually training in the broader context of the mental health experiences. And do you want to add any more to the comments that have been made as to where people should be going and thinking about?
Yes, I think drawing on what Firas talked about, finding out what people really want, what your audience wants, being very flexible and adapting to the setting. So if you're a mental health specialist and you're asked to go out and do some training in primary care, you've absolutely got to go out and talk to GPs and members of the practice team. Preferably, you've got to have them on board working with you. Because otherwise people assume that you've no idea, and you may not have any idea what you have to do in 10 minutes. And I learned that very early on. Always work with a co-worker from primary care. Providing training that, don't believe all the hype about training. Training on its own isn't enough to reduce the suicide rate. We know that. We did research on that pretty early on, but some people will tell you it is, but the evidence so far is that it isn't on its own. It's part of a wider system, but do look at what research has been done when people talk to you about offering training. Has it actually been formally evaluated? And I think that's important. And think about the fact that GPs work in a different payment system from those of us in the rest of the NHS. So they need time, they need backfill of their time to attend training. And the most successful training I've ever done with GPs is where I've actually gone out and done it within the practice. I've gone to them, and people may say, oh, but surely they can come to training. My experience was that you tend to get the same 10% of people coming out to training events. And very often they're the ones that don't really need it. But the most successful training we did was where we actually went out and offered training on site, and got the whole practice engaged, and at times that suited them. So you have to be very, very flexible and get people on board.
I think you've addressed one of the other points that somebody was raised about how do you actually engage? Because it's sometimes easy to preach to those who actually are already converted and want to do it, but we can't deny that not everybody finds this area comfortable or wants to pursue it. And I think those ideas about working together, is there any other ideas in terms of that? And is there any merit in extending that collaborative approach to the training? As you described, that you have the whole practice there, may have some advantages on just having one professional there. But I've got a vision in my head about having all the people from a community there, as it were, so other healthcare workers. But is that too complex and too difficult?
I think you have to bear in mind that people work in different settings. Primary care is about fast consultations, and it's very much about what you can do today in this 10 minutes. People in other settings work in different ways. They think they think ahead. You know, it's when I remember some psychiatrists telling me, you know, you can talk to me next week at 11:15, you know, to a GP. And a GP said, well, I want to talk to you today about this patient. You know, my life isn't quite timed in that way. And I think that's really important to bear in mind. It's a different culture.
That's important for us to be mindful from all sides of that equation with all of that. And we've had the comments again, and I think Sorab started, and you've all alluded to it in some ways, that 10 minutes consultation. I believe there's an awful lot you can still do in 10 minutes. I think, you know, just 10 minutes isn't necessarily the major barrier and obstacle, but there's something about the need to maybe, when there is more time needed, how can that be managed? Is there anything you want to add to that, Linda? And then I'll work back through to Firas and Sorab on the same bit.
When I spent years researching consultations in primary care, I was actually amazed how a good GP could get down and make an empathic connection with someone, particularly if they knew them already. And that's where the point that Faraz was making about continuity of care is very important. That connection can be made quite quickly. And I compared that with, I've looked at a lot of psychiatrist consultations, and I can say that experienced GPs are incredibly efficient at using that time, but that doesn't mean that you can always do it in 10 minutes. And I think that longer is required for mental health consultations, but I think GPs know how to use time much more efficiently than many of us in psychiatry do.
That's a very, very interesting and valid observation. For us, I suspect you'll support that. Is there anything you want to add to kind of that 10-minute opportunity or 10-minute restriction that's there?
Yeah, no, it's a really interesting question. I think we're going to be hopefully moving away from this 10-minute kind of, what's the way of talking about it? Expectation of having a consultation of only 10 minutes. The Royal College of GPs have long been talking about longer consultations. I know a lot more GPs now in my area in Birmingham are choosing longer consultation times. I think impacted by the experience of consulting in COVID. What I would say is that we talk about the exceptional potential of the GP consultation. There is still good potential within that initial opening consultation, and within a usual GP clinic where you might see 15, 20 patients, all of those interactions are going to be of different amounts of time. And often mental health consultations, you do spend a bit longer with people. So I think the majority of GPs are flexible with their time. Again, the initial appointment's really important. Training, needs to include, what to do in the opening appointment, but also really highlight that the opening appointment, if for mental health distress, suicidal thoughts, self-harm, should not be the last consultation. I think this is going to come out in the nice self-harm guidance. It's come out in our work and colleagues around the country around continuity of care, and not to leave people hanging by just that one consultation and then not seeing how they're getting on again.
Thank you. And so, Rob, on the same sort of theme, but thinking a little broader with that, is primary care isn't just about the GPs. There is a whole host of professionals that can have those conversations with somebody and share and may be able to manage, and sometimes embedding some more specialist related workers within that primary care team may provide that access and that opportunity. Is that something you see potentially happening and developing, or is the scope for that?
Yes, because the additional workers that are coming into primary care include mental health workers. I think there's going to be 1 per 100,000 and then another 1 per 100,000. I think we'll end up with sort of 2 or 3 per 100,000 by the end. But you can also use occupational therapists as well, many of whom have a mental health trained background as well. So you can actually use these staff within primary care and within PCNs to see patients, but also to support the GPs and also to link up with the community mental health teams of the future. So I do think that it will be better that way in the future than it has been, which is great.
That's probably a question more directed to yourself because of your knowledge about the database system. Somebody's asking about EMIS, and is anybody using that to proactively search for patients who are high risk in order to prevent deaths by suicide? I just want to add a caution in my own thinking. I worry about us thinking just about high risk, because we know that just because somebody is high risk, it doesn't mean it's inevitable that they will go on to act on those thoughts. Indeed, the person with a low risk or almost an absence of risk could very quickly trip into being a high risk. So yes, using the databases are useful, but we've got to be careful not to become over-reliant on them. But going back to the question,
sorry, Karen.
So as I said, the clinical practice research data link CPRD uses practices who have EMIS, who work on EMIS, on the EMIS software. So through bringing together lots of patient data anonymized around the country from EMIS systems, yes, researchers have looked at important factors, associations, whether it may be from number of medications prescribed, diagnoses, referrals generated, for example, to work out, who may be more at risk, but also aftercare, after consultations, and also management of people, what types of medications they could be prescribed with a consultation about suicidal thoughts or self-harm or depression. So all that work, all that epidemiological observational work is ongoing. The usefulness of it, Keith alluded to it. It's not, kind of something that we need to bear it in mind, take it into account, but suicide risk changes, it's fluid. And I think just really highlighting that every encounter with someone in distress is important, so trying to make every contact count. And I've talked about the wider team. So yes, clinical pharmacists and PCNs can now advertise and employ other people to come and join the primary care team who may have a focus on mental health. I think what could happen, my thoughts are that those people in mental health distress, suicidal distress, may still come back to the GP, or those colleagues may still work alongside the GP in providing care. These areas are complex, but certainly it'll be great to have more support within the primary care team from colleagues coming into the team through these new NHS schemes.
Thank you, Firas. We're running close to considering this probably to be the last question that's there. And I guess I'm going to direct it to start with Linda. And it's something about collaborative care and how that can be incorporated in terms of CAMS or in terms of the young people's bit, because there is, I suspect, and I observe very much a tendency, and forgive me if I offend anybody by that, but when a young person shares suicidal thoughts or self-harm thoughts at a GP surgery level, that the most regular response is a referral to CAMS, and they are massively overwhelmed by all of that. I know there's a lot of work done by Eleanor Townsend that's actually supported, I guess, what I've just said in an observation. So how can we move that collaborative care into children's related bits, particularly CAMS services as well? Is that a possibility, Linda?
I hope so. But I mean, historically, there has always been this referral model. And I spent quite a lot of time looking at alternatives to that traditional referral model. Having people embedded within a practice, working in a collaborative way. I think we have to move to collaborative care for CAMS, where you have a worker who works more closely with the practice, but is also supervised and their work overseen by someone within the team. That's the way I started to work as an adult psychiatrist latterly. And it's an awful lot more efficient than me sitting in a GP practice just seeing patients when I don't see very many. Whereas working with someone who's working in the practice all the time, supervising, I can supervise a lot of people. And so you have to think about this difference between using your skills across a whole range of people and just working with individuals. And I think that's one of the things about collaborative care. You can spread that expertise. And I know there are one or two places in the UK that are doing that, but it's not a common model.
Thank you, Linda. And finally, to yourself, so anything you want to add about that collaborative care, particularly for young people and with the CAMS, from what you experience on a day-to-day basis as a practicing GP, as well as the things that are perhaps trying to be evolving within the local communities?
Well, I would agree that the GPs need support and help with young people at the moment, because, I mean, it's a big part of our workload in terms of seeing new presentations of mentally unwell or distressed young people of all types, and knowing what to do. And of course, the CAM services have the threshold still, even though I can refer patients to a commissioned service that might be less than CAMS, you know, what about still commissioned, still mental health trained people, but they're not dealing with the highest severity. The waiting lists are too long, so, you know, 16 weeks and things like that. Better than it was, though, because we're putting more money into it. But I do think that there needs to be some kind of interface between support between GPs and specialists or services to be able to keep people safe and look after them while they're waiting.
Thank you, Sarah. I think that's really useful. And we started with collaboration as being part of a really important part, and we've probably ended with that. Hopefully more optimistic that we should be moving towards that and celebrate that that's happening. So thank you. Bianca. You're muted, Bianca. Sorry.
Thank you, Keith, for the prompt of putting myself on mute. Haven't we heard that a lot over the last few years? Thanks to everybody who's attended today. I can see there's a number of you online. A special thanks for Keith for chairing such a lovely event. Linda, Sohrab and Faraz, what a wealth of information. And I think what we've seen here is that there's a really long history of a place for primary care in suicide prevention, and that is really apparent. That has been around for a really long time, and those working in primary care really do have an opportunity to make a difference to people in distress. Also, there was something about there being an opportunity for being in contact with people that aren't in those specialist services, but also a real need for primary care to feel the backup of specialist services as well, in that, you know, if they are in a sticky or troubled situation, that they feel they do have that backup. And there is something about the theme of making those links and communicating with various services. And that's easy for me to say, but it's not easily done because people are complex and we work in complex systems. There's also some key things that I was hearing about what GPs and those working in primary care can be doing. And it's one of the key things is about being human, isn't it? You know, making that empathetic, compassionate connection with somebody and understanding their story. And yes, 10 minutes isn't always enough, but as Sohrab has also pointed out, GPs or primary care isn't just about the 10-minute slot. There are other options. Also, there sounds like there's a review of that 10-minute arrangement, particularly needed around working with people in distress, which I will agree with. There's also something about safe prescribing and reminding ourselves about the importance of limiting access to means for ending life, I guess, in our safety plans, and also those safety plans ensuring that they're done in a collaborative way with people in distress. I really like the thoughts about us expanding this idea of everybody having a role in suicide prevention. And I was really heartened by the talk about even pharmacists. I recently had a really good experience with my pharmacist, which would mean that I would go back to that pharmacist again to have a chat with them. They took me off into a private room where I could tell them what was going on. I just thought it was a really useful thing to do. And dentists, goodness gracious, you're in that chair with you know, in a really vulnerable situation. So, you know, there's another opportunity there for us to be working towards suicide prevention. So I thank you all for your time, your expertise, and also your messages about how primary care can help to prevent suicide. We are all in this together. A reminder to all of us about our own, am I sharing the right screen there? Nod if I am.
You've got the emotional safety slide.
Yes, that's the one that I wanted. So Oops, I'm pressing the wrong thing. I'm just going to share that again. So just a reminder to everybody about their own emotional safety. If you do need to reach out and chat to somebody, particularly if you are in primary care and have been impacted by suicide or a serious incident, you know, how are you getting support? Also, thank you to my amazing team behind the scenes. There's a number of bodies working behind the scenes to make sure your questions were answered, registrations and the technical side of things went smoothly. A special thanks to Danny and Kirsten for that help, and also Becky for helping translate some of your questions. So thank you in the background. We'd really encourage your feedback as well, guys. So you will be sent a link with an opportunity to provide us with feedback, and also tell us what you want in future. Slides will be available on the website, and we will send you an email to remind you about when they're available. Thank you all so very much. Have a lovely afternoon. Take care, and we'll see you again soon. Thanks all.